Thanks, Jennifer. Thanks everyone for joining. So as Jennifer mentioned, today I'll be talking about one of the projects that's funded for the Can Rehab team. This is an electronic prospective surveillance model that we've been developing and are launching very soon at 4 centers across Canada. So part of the project has involved a previous scoping review, actually, that I presented here last year. And today I'm going to show some results of a qualitative study that we've been doing over the past couple of years, meeting with various stakeholders of our cancer centers that were implementing this system. So just a bit of background, the recent report from CCS does show about 1.5 million cancer survivors, or people in Canada living with a history of cancer. But what's very interesting from this report showing that about 60% were diagnosed 5 to 25 years ago. So you can see this in the chart here, where common cancers like breast, prostate, and colorectal, you see about 2/3 sometimes people living that are past the diagnosis 5 to 25 years. But we also know that these individuals have persistent side effects and are dealing with these side effects that can cause disability at many times. So some of these adverse effects is the slide you may have seen Jennifer use before, but what I like here is that it shows the level of severity can differ across these different cancer sites, and this is due to the different adverse effects that patients may be experiencing that are unique to their cancer and their treatments. But there are also these cross-cutting symptoms that are very common across the cancer sites, such as fatigue, pain, and deconditioning. So in terms of, we've actually developed our system, which I'll show you in a bit, to have these cross-cutting symptoms, but also a couple of unique symptoms per cancer site that we're implementing this in. So we did take this into consideration. This is data from a survey conducted a while ago from the Canadian Partnership Against Cancer, just showing that the amount of individuals with moderate to high levels of fatigue, anxiety, pain, and depression. And so while there is a majority of patients who experience more mild symptoms, there's still a significant proportion that experience these moderate to high levels. And so even those with mild symptoms can definitely benefit from more self-management and patient education, but we do know that there are supports that these patients need. We also know that this continues after treatment from the same survey. So we see that about 80% of patients post-treatment had challenges in terms of a physical impairment, typically fatigue, 70% with an emotional concern around fear of recurrence and depressive symptoms, and 40% had challenges with more practical considerations, such as financial problems, getting back to work, extra costs, and insurance. So we do know that there's a need for these, for more support during and after treatment. And this is actually, we know that failure to do so can lead to poorer health and disability. And so this is an older survey, but it's here shows the difference between those with and without a history of cancer, in that those with a history of cancer report poor health, more limitations with their activities of daily living and functional limitations, and more challenges with getting back to work. And in terms of why individuals might not be using rehabilitation services, there are a couple of different reasons for this. And this goes back to the survey from the Canadian Partnership Against Cancer, and it provides some context into the underutilization of rehabilitation services. So we can see that some common responses were that patients thought it was normal, didn't think that anything could be done. They didn't want to ask, or they didn't know that there were any services available to help them. So this is where an electronic prospective surveillance system can really be a beneficial intervention. And what an EPSM is, the model, it looks like this. So patients register at different time points depending on the model that you choose. But patients along the way of their treatments would be answering electronic patient-reported outcomes. Again, these depend on the different symptoms that want to be targeted, either during or after treatment or depending on the cancer site. Based on those scores, either the clinician or the system can provide different recommendations ranging from patient education all the way to hospital programs. Different Trials have shown that this is beneficial at improving symptom management, physical function, and also reducing emergency use. One trial also showed it's associated with reducing overall survival. And it also improves patient-provider communication of symptoms that might not otherwise be discussed, something like, let's say, sexual health. But what we don't know is really how do we implement this into a routine clinical care setting. So moving from a trial to actual real-world implementation. Some of this is around the intervention itself. So determining risk stratification criteria, guidelines for different referral pathways, depending on the symptom, but also in terms of the different clinic workflows that there are in different clinic structures, as well as the different resources that might or might not be available at different centers. So just to summarize, the rationale here for this type of system is that we know that failure to treat these side effects can result in negative outcomes in terms of function and disability. We also know that many of these impairments are underreported and unrecognized, but there are different interventions that can help ameliorate these symptoms. And again, these range from education to all the way to comprehensive rehabilitation programs. And we also know that few survivors receive that type of care. So we've developed the REACH system, and the REACH system was developed at UHN, working with the Healthcare Human Factors team and the Detective team who've designed this system. I'll just show a video shortly, but this system was designed in partnership also with the Patient Family Advisory Council that gave feedback on what the system should look like and how often maybe the question should be asked. So I'll just show this video because it provides a little bit more context into the actual system and its design. Just let me know if anyone can't hear it. Okay, it looks like it's a little choppy. Maybe one more try.
REACH is an online tool that empowers you to manage your side effects from treatment. People with cancer face many health challenges during and after treatment. These side effects can negatively impact their quality of life and make it hard to get back to their regular activities. There are many resources that can help manage side effects from treatments. But these impairments often go undetected, and only a small number of people get the support they need. REACH helps solve this problem by giving you a place to go to track your symptoms and receive personalized information and support along the cancer pathway. You can access REACH on any electronic device such as your smartphone, tablet, laptop, or desktop computer. And you can simply create an account for REACH using a personal email and password. Once you register into the system, you will be asked a few questions about yourself, your cancer diagnosis, and where you are on your cancer path. Based on this, the REACH system will tailor what questions you will receive and how often. REACH is easy to use and only takes a few minutes to complete. When it's time to answer your short screening questions, you will get an email and be asked to log in. REACH is a remote system, meaning that you won't be answering these questions when you come to the cancer center and can answer these questions anywhere and on your own time. Based on your answers, REACH will provide you with resources to help manage your symptoms. You may be offered resources such as videos or pamphlets or suggestions for referrals that can be helpful to address any issues you may be having. REACH is meant to help you get the right support at the right time to manage your symptoms and improve your well-being during and after treatment. Let's take control of your well-being and register to REACH today.
Okay, can everyone still hear me? I couldn't hear that video for the last couple
seconds.
Yep, we can hear you.
Okay. I can't hear anything. Just give me 1 second. Okay, can everyone hear me now?
Yep, we can hear you.
Seems like I can't hear you, but as long as you can hear me, I think we can move on. Yeah, okay. So these are the symptoms that are being targeted for or screened for the 4 different disease sites. So it's being implemented in breast, colorectal, head and neck, and lymphoma at first. And this is just for the purpose of the grant, of course. So across cancer sites, we have things like fatigue, pain, and falls in balance, but you can see there are some specific and unique symptoms for the different cancer sites. And this was developed through a survey with various clinicians in the grant, in the team. And we rank ordered them and chose the top 5 symptoms for each cancer site. You can also see here the frequency. So this is not meant to capture acute symptoms like other systems that might be doing this at a clinic visit or weekly. This is really meant to track those. Sorry.
Code white 8 Eaton South, room 418, the PICU. Code white 8 Eaton South, room 418, the PICU. Code white 8 Eaton South, room 418, in the PICU.
So this is meant to track the persistent symptoms. So the frequency during treatment is 3 months for the majority of these symptoms, and then the 3 months will continue for the first year, and then it'll be 6 months in year 2. So we are tracking these symptoms up to 2 years post-treatment. And each symptom, I'll just give an example of one, each symptom has a logic built in that will be updated to better detect, when a patient might be asked a question or better have a better response. But for example, fatigue would be every 3 months, and you can see here, depending on certain questions that they answer, they would be given different resources. Now, in terms of the implementation of this, this one study that I'm going to present is part of a larger program of research on implementing REACH. It's the Knowledge to Action framework is a framework, it's a process model that helps identify the different steps needed to implement a healthcare intervention. So this project was looking at assessing various facilitators in hopes to select and tailor specific interventions, specific implementation strategies to actually implement REACH. And then we were always thinking in terms of our implementation strategies, what might be feasible, what might be sustainable down the road. It was also informed by the implementation research logic model. And again, what we're looking for here is determinants, so barriers, facilitators. Eventually, what we're going to be looking at is how those strategies work and how that leads to our different implementation outcomes, service outcomes, and clinical outcomes. So the objective of this study was to assess and identify different barriers, facilitators that can inform the development of a tailored implementation strategy for REACH. And this might be a little bit different at each of the sites. So again, it's a descriptive qualitative study. It's conducted at our 4 cancer centers that were implementing the tool. So Princess Margaret, BC Cancer, St. John Regional Hospital in New Brunswick, and then Dr. H. Bliss Murphy Cancer Center in Newfoundland. We looked to have individuals that were relevant in terms of different stakeholders in inputting the implementation plan. So this would be patients from our patient advisory committee, clinical staff, such as physicians, nursing staff, rehabilitation staff, and then the site leadership, so different management and clinic leads across the different centers and across the different cancer sites. The study was also informed, the interviews informed, a lot of codes there.
8th floor, PICU, room 418. Code white, Eaton Wing, 8th floor, PICU, room 418. Code white, Eaton Wing, 8th floor, PICU, room 418.
So the study was informed by the Consolidated Framework for Implementation Research. So this framework is a determinant framework. It has 5 different overarching domains that can help inform different implementation research. The first is the domain of the inner setting. So this involves things around the clinic workflow, the different structure, the culture, and its climate. The second is around the characteristics of the individuals. This would be patients and clinic staff, their knowledge, beliefs about the system. The outer setting, so outside of the cancer center, how they're connected with different organizations and different programs, different external policies and incentives that might be coming down either from the center outside of the clinic. And then also intervention characteristics. So the system itself, in terms of its adaptability, its complexity, and I'll explain this a little bit when I actually inform the themes and results from the study. And then lastly, the process. So this different processes in terms of planning the implementation and engaging different stakeholders, opinion leaders, champions, and also methods in terms of reflecting and evaluating on the implementation process. So these 5 domains helped inform some of the questions that we asked different stakeholders and then inform the analysis. So in terms of data collection, we decided to conduct either one-on-one or group interviews. It was a pragmatic decision in that it depended on the individuals being interviewed. For example, clinic leadership usually would be one-on-one, but if it was, let's say, physicians, nursing staff, things like that, that tended to be more group interviews. Each interview, the participants would be provided with a brief video just explaining the system, and that would be presented before, so a couple of days or a week before the interview. Then the interview would start with a presentation of the system and the initial mock-ups that we had of the design, and then the interview would begin. The transcription, we initially used the in vivo platform, but we switched over to a different platform called Deduce for the rest of the coding. The way the coding worked is we had 2 coders, and we used an initial template of the CFR that's available online with all the different codes and the code descriptions. And that really helped us then adapt those descriptions for the REACH system specifically, because the descriptions are very general and meant for any healthcare intervention. Then finally, or not finally, but then we moved over to the initial independent coding. So the 2 coders, including myself, we coded a couple of different interviews. We met to agree on certain descriptions and codes, and then refine that code book. And then we went through all the different constructs of the CFR that were identified, compared and contrasted the codes within that construct, and made a final decision of what was to be remained within that construct. We had a final list of codes within each CFR construct that we then did a bit of an inductive analysis for the relevant sub-themes within that construct and domain. So I'll talk a little bit about first just how many people we interviewed. So we had total of 22, about 40 minutes long, and had 56 different staff participants across the 4 centers. You can see there were a lot more interviews done at Princess Margaret, just because of the complexity of it. And also the patient advisory committee had 14 individuals. So first I'm going to talk about some of the constructs that were more relevant. I won't go through all the different constructs that we identified. I'll talk about the more relevant ones, beginning with the intervention characteristics. The first was around adaptability. So this was looking at in terms of how we could, how rigid was the system, or how flexible it was. And so some of the feedback we got was a potential barrier around the factor of patient variability. So the various treatment types and durations that patients might be going through, sometimes going through, 5-day radiation versus, more longer treatment durations. and not being able to have that symptom screening be more often for those patients, as well as the language. So the system right now is in English, and so the barrier would be if patients don't know how to speak English, and if they don't have someone that can help them answer those questions. But a facilitator was, alternatively, the flexibility of that system. So the ability to actually register at any time during treatment was seen as a benefit, and not having it, let's say, where patients had to start at beginning of treatment or beginning of radiation treatment or post-treatment. They are able to register at any time, and that provides more windows of opportunity to be comfortable when and where they want to use the system. But also the level of tailoring that there is within the system, it was a benefit. So, the symptoms that are being targeted are, there are unique symptoms being targeted for different cancer sites, and the resources are different depending on those symptoms for the different cancer sites and during and after treatment. So one of the patients in the patient advisory committee mentioned that I love the idea of constantly reintroducing it and being able to register at different times. Because maybe chemo is an easier ride, but when you have bilateral mastectomy, you may need it, you never know. So again, just highlighting the fact that it's good to have it open at different time points because maybe they're not very symptomatic during one treatment versus another. The second factor of the intervention was its potential relative advantage. So one of the disadvantages or potential disadvantages in terms of a barrier was this concern about a potential overlap with discussions or recommendations from healthcare providers that is provided to patients. So in terms of the resources that are provided, but also the questions asked and the symptoms being targeted. Patients also had some concerns of if this was going to be asked more often than 3 months, then a potential of replacing the personal connections with the healthcare provider. And so they just wanted to ensure that that wasn't the case. So one of the patients mentioned that the conversations and dialogue are essential. I'd be concerned you're using technology that's going to create this algorithm of care that diminishes the personal contact for me with my team. Alternatively, a facilitator was this sense of having access or centralized access to a place to go for trustworthy information and avoid different internet search engines. So this patient mentioned Reach is almost getting in the way of Dr. Google, and I really applaud that. It's kind of a personal resource for information as opposed to falling down that rabbit hole at 3 in the morning of the internet. So again, just having that reassurance and a place to go to when they might not know if what they're experiencing is normal or what they can do about it. And then another facilitator was this notion that Reach, unlike some other systems, provides an instant response to patients. So when they fill out their screening questions, they don't have to wait to get a recommendation or a service. Reach actually provides a recommendation right away. And this was seen as a very beneficial because they're actually getting something out of their responses. And then the final and third characteristic around the intervention was the complexity. So some staff did have some concerns because it is a remote system where patients are completing this outside of the center, that they might have some difficulties around technology and how that would actually be addressed if they had questions and issues. There was also this concern around at the time, we hadn't known if the scores could be or would be provided to the clinicians and how that data would be fed back. And so managing those high scores, especially if it's remote, was seen as a potential barrier, if that's the case. So staff just noted that they want to be, sorry, I'll just mention this quote here, that from a staff, they said trying to pick up severe dysphagia of the patients that are aspirating is extremely important. But since Reach is not generating the symptom data to clinicians, isn't there a risk patients will say, yes, I'm aspirating, and assume that we know that because they put it down in the app. And so the recommendation actually provided by the staff was to make this a more patient-directed tool and process, and make that obvious for the patient. So this quote mentions, I do like the idea, and this is from staff, of having an alert for the patient stating they had a sudden increase or drop in the symptom. or they're on one extreme end of the scale. So review this with your physician. Again, making it more patient empowered, so that they know that they have to schedule a visit to get that symptom addressed. So I'll move on to the outer setting. And in terms of the outer setting, the first thing that came up was around patient needs and resources, in terms of filling gaps in care that are present. So patients had this, or mentioned that they had maybe a better sense of reassurance using this app, but eventually, due to the variety of symptoms that they may experience and services that they might not be aware of. So staff mentioned patients can start to feel that disconnection with the cancer center when they're finishing treatment, and even insecure because they're going to be back in the regular environment without the support of all the team. So I think it's a great project. So again, just highlighting the fact that there's that sense of reassurance and connection, especially post-treatment. Now, cosmopolitanism is about the level of organization and connection that a clinic has with other programs and centers. So one of the barriers that came out here was some centers, particularly those out east in Atlantic Canada, did mention that there was this concern of not having enough resources to provide to patients when those symptoms are identified. So they mentioned, again, the challenge we have in Newfoundland is we don't have the portfolio of services that some of the bigger places have to address these issues. And so we had to really think about, different online programs and nationwide online programs that we could provide on the app to help us to facilitate or address that gap. But there was also this facilitator about this sense of connection to services, and that it could reach potentially, because it identifies that gap of not having a lot of programs. It could spark a need to build more, but also if there are existing programs out in the community, it might help build that connection between the cancer center and the community. And then the third was around the external policies and incentives, really about the consent and email policies. So emailing patients information about REACH may not always be possible in all the different clinics due to different privacy issues, and also clinician use directly to patients is not always used by staff or not always encouraged. Now, the last and third domain I'll talk about today is the inner setting. And this was the most relevant and talked about domain in our interviews. The first was around the structural characteristics of the clinics and how those differ across the 4 centers. A potential barrier was that the clinics in some areas are dispersed. So for example, one staff in Newfoundland mentioned that the hematology team right now is outside of the cancer program. They don't use that same area like the other cancer sites do. So I just want to point out that, and we're going to get that part, but the hematology might be outside of that, at least temporarily. The rest of the sites are consolidated, so it might be easier. So again, just highlighting that having those clinics all together, it makes it easier on our end as well, because we're able to coordinate different meetings and people talk about the REACH system when they're all in one place. The second was around how ready these individual centers were in terms of the staff time. So one barrier was that staff were concerned about not having time to explain the system, and if patients had questions or didn't know how to register, that there wouldn't be time to actually go through that with the patients themselves, or that relying on staff to actually introduce the systems as opposed to other processes might be a barrier, and we might not get a lot of patients registering that way. So the staff mentioned, I don't think the clinic staff will have enough time to explain it in enough detail. If you depend on staff, I think it's going to fall through. And I just know how hectic clinics can get. Now, the implementation climate is another subdomain within the inner setting. This theme really revolved around the other symptom reporting system. So some centers, particularly in, let's say, Princess Margaret, but in other centers too, like New Brunswick, There might be other symptom reporting systems used during different phases of treatment in particular cancer sites. And so coordinating not only when patients are learning about that system and ensuring they're not learning about both at the same time, but also coordinating, potential overlap in terms of the symptoms being targeted and the resources provided. So that was seen as a potential barrier in terms of patients not knowing the difference between these various symptoms. So this staff mentioned it would be important to make sure you draw a distinction between the purpose of this system versus the patient-reported outcome measures that we're doing, because you would potentially have patients who would be offered both. At first, both systems are going to seem similar, and they might not understand why they're signing up for two different things. There was also other clinic initiatives and priorities. So different systems being implemented. At Princess Margaret, there was, and BC Cancer, actually, there was a new EMR system being implemented. And so there is a sense that having another implementation project, even if REACH is very hands-off, is seen as very difficult to navigate and think about in terms of the process at that time. So this staff mentioned I would suggest not to go live right now. The learning curve for Epic in the clinics is going to be huge. People won't have the time or bandwidth for anything else. Now, in terms of facilitators, what was recommended was actually, and this goes back to the not having enough time and resource for staff to actually introduce REACH, was to integrate the awareness of REACH into various electronic systems or educational encounters that patients are already using. So, for example, this would be a patient portal, education packages, different education classes. And so this staff mentioned we have processes for providing patients with information. It might be good if we integrate REACH into our existing processes. If a patient is going to start treatment, they get a whole package of information about their treatment. If the information about this system was in there, then that might be helpful. So again, just a way to better integrate REACH into the clinic processes as opposed to adding another task that the clinic staff have to remember. So I didn't talk about the individual characteristics just for the sake of time today, but that really just revolved around the knowledge of the system. So just ensuring patients and staff are aware of the purpose of the system, what symptoms are being targeted, the frequency of reporting, and the different resources available. And then the process domain really involved around highlighting different individuals that are important to engage with, specifically the clinic leadership, individuals that have more opinion roles and managerial roles in the clinic, but also the variety of different stakeholders that we were meeting with already, such as the nursing staff, radiation therapists, et cetera. So just to summarize, so we know from the literature that the implementation of evidence-based practices and interventions is highly dependent on the local context, but also on the level of tailoring of the implementation strategies. So that level of tailoring has been shown to increase implementation success, typically done through an assessment of different resources and various facilitators before implementation. The findings from our study have really helped identify what barriers to avoid and facilitators to use and to enable our implementation of REACH. And this really includes things around the system design. So we did use some of the feedback to inform the system. So in terms of ensuring the questions aren't being asked, they're not too long, the questions aren't asked too frequently, and so forth. The clinic workflow processes and priorities. So just ensuring we're implementing REACH at the right time, that we give a clear process of how REACH will be, how patients will learn about REACH, and ensuring that it's a more automated process. And then also looking at the availability of resources and meeting the needs of patients around the outer setting.
Your attention, please. Code white, all clear. Code white, all clear. Code white, all clear.
So these results assisted, and this was in combination with the scope interview that I mentioned, in selecting our initial implementation plan. And I'm just going to talk about some of these strategies that were that we're using and how we're going to evaluate reach very briefly. So the first is we've developed and distributed, and we're going to distribute different educational materials, one of which is the video that I showed previously, others poster and this handout. The way it's going to work is actually, we're going to try to make this very easy for patients to learn about. So we're working with different experts around the different electronic systems in the different centers to try to integrate the awareness of reach with those systems so patients can easily find out about the system. So this includes Apprentice Margaret, things like digital education prescription, where patients are, it's a portal where patients are provided with a list of different resources the clinician can tick off. So we'll integrate the reach handout and video in that package. And so patients would be emailed that reach link and video within the other resources that they're provided. We'll be able to put a prompt of reach within a patient portal at Apprentice Margaret. And then at Newfoundland, for example, we have the ability to integrate reach into an electronic nurse checklist so that nurses are reminded to talk about reach when they're seeing a patient. We have also been conducting various educational meetings at rounds with physicians, meeting with the different nursing staff and the radiation therapists to promote the system, but also let them know what symptoms are being screened, their frequency of reporting, and the resources that patients might be recommended. And then telling them about the different processes that I've just mentioned about how patients would learn about the system. Because it's a technical, it's an app, right? It's a web app. We have a technical assistance plan. That'll be actually managed by the research team for the first year and a half, just to see how sustainable it is and provide any feedback down the road. But this will help answer questions that patients have about the system, but also any technical issues that we need to be made aware of. But patients would be prompted that with an automated response, just for safety reasons, ensuring that they know that this is not a clinical email and that their physician won't know. So they can't be asking questions about, let's say, the symptoms that they reported on the system itself. And then we also have a quality monitoring system. It's built into our evaluation of reach, but we'll have these 4-month cycles. We'll be using data collected from the reach system, from patient surveys, and then down the road from interviews to really refine the system, refine the implementation plan. So if we notice, for example, that certain cancer sites have a higher registration or higher use of the system, we'll know that and we'll be able to make necessary adjustments along the way. So as I mentioned before, we're using this knowledge to action framework to inform the entire project. And so the next steps would be to look at how reach is being used in terms of a process evaluation, and then evaluating our implementation and clinical outcomes down the road. And this is the same with the research logic model. So we'll be able to look at how our strategies are working in terms of the uptake and feasibility and use of the system, and how that relates to our outcomes. So this is going to involve a mixed method study across all the different centers, where we'll be using survey data, system data, and also qualitative data to look at the feasibility, acceptability, and a variety of different implementation outcomes. And eventually we'll be able to look at whether patients are actually, their symptoms are improving as well. But I'll just end there. I'm just happy to take any questions from anyone now.